think we can get started. So thanks everybody for being here. This is the AO webinar on updates in the management of patellofemoral instability. I'm joined today by my esteemed panelists, Dr. Seth Sherman, who's an associate professor of orthopedic surgery and the fellowship director of sports medicine, as well as a head team physician for Cardinal football at Stanford. And then, of course, we have Dr. John Fulkerson, who is a professor of orthopedic surgery at Yale University and president of the Patellafemoral Foundation. And I think they're going to give some great talks today and give us some insights on the medial patellofemoral ligament and complex, as well as other procedures in treating patellar instability. These are our disclosures. We'll indicate if there's anything relevant to our talks, which I don't believe there are currently. And I also wanted to acknowledge the funding for the educational activities for the AO Foundation from Synthes. And I should also note that all of the educational resources are owned by the AO, and the contributors are for these are all for educational purposes. So some other kind of housekeeping here I just wanted to make note that AO North America is an independent nonprofit surgical specialty society dedicated to improving the care of patients with musculoskeletal injuries. It does not endorse or promote the use of any product or service of commercial entities, and that the equipment used in this course is for demonstration and teaching purposes only, with the intent to enhance the learning experience. Just as a reminder, please remember to keep your microphones on mute and your video cameras turned off. If you do have any questions, we'll be monitoring the Q&A. And so please type your questions into the Q&A box, and we'll have a time for discussion at the end. And we'll be able to present these questions to the speakers. The chat box, I don't believe, is active for the participants, just for the faculty. So everything will be through the Q&A for the audience. Thank you. So this webinar, the goal of this is to provide an update on the latest principles and the techniques regarding the surgical management of patellar instability. So our faculty today are going to review the surgical treatment algorithms and technique pearls in their discussion of MPFL surgery, as well as when and how to address concurrent pathology when treating patellar instability. At the end of this session, learners should be able to identify the surgical treatment algorithm for patellar instability, describe how to avoid complications during MPFL reconstruction, and outline when and how to add the treatment of concurrent pathology in addition to MPFL reconstruction when performing surgical treatment of instability. So we're kind of wrapping up our welcome and the introductions. I do have a few more slides here. The first talk will be by Dr. Fulkerson, who's going to be giving a talk on the updates in MPFL, QTFL, and MPFC reconstruction, and going over principles and how to avoid complications. This will be followed by Dr. Seth Sherman, who's going to talk about when and how to address concurrent pathology during MPFL reconstruction. And at the end, we'll have some time for a panel discussion as well as some Q&A. So please feel free to just enter your questions into the Q&A box, and we will get to those towards the end, or maybe even between the talks. And this will be a 1-hour webinar. So just a few reminders about some upcoming courses. The Principles course is coming up in August in Nashville. This is a 2-day course that introduces the principles of sports injuries through a variety of interactive educational modalities. There's arthroscopic simulations and practical exercises, 3D animated tours, and case discussions. The modules and small group discussions will be moderated by world-renowned expert faculty, and this is the stepping stone to AO Sports Advanced and Master's courses. Having been a faculty on this, I think this is a great opportunity for people of all levels, but especially for residents and fellows. And so you can see here, there's a QR code and a link if you'd like to sign up or like to send your trainees. Additionally, there is the shoulder course, which is going to be held in Boston on November 14th through 16th. This is the shoulder tendon transfers and rotator cuff repairs course, chaired by Dr. Bassem El Hassan. It's a 3-day course inclusive of 2-day didactic lectures and 1-day anatomical specimen lab. And this is for people to learn about current evidence-based techniques for shoulder tendon transfers, complex rotator cuff repair, diagnosis and management of scapulothoracic abnormal motion. And so this, there's a QR code here as well for anyone who might be interested in this course. Other courses coming up, or we have some webinars as well. There are all of this information, I'm sorry, can be found online, and this QR code can be used to access any upcoming courses or webinars that are available through the AO Foundation. Thanks very much.
All right. So thank you, Miho and John. And I'm really excited to be here. I've been involved with AO Sports as well. And that course is amazing. So, and obviously, we're all very passionate about the patellofemoral joint. My task here tonight is to go through when and how to address concurrent pathology with MPFC reconstruction. We'll get to John in a bit, and will give us all the information we need to know about the MPFL, the MPFC, and the MQTFL as obviously part of the MPFC, but we'll kind of take this a step further and try to put it all together in some sort of a workable algorithm. My disclosures, as Miho showed, are available online. One of my main disclosures that John is always looking over my shoulder and Miho's shoulder, and really our true king and ambassador of the patellofemoral joint for the world. And so hopefully we do this justice for him here today. As John will tell us, and as we all know, isolated MPFC reconstruction is a great operation. I mean, it is really our workhorse for patellofemoral instability, and we should and will spend a lot of the time learning why to do it and how to do it and how to do it well. And so really, my task is to take it a step forward. When do we need to do more than an isolated MPFC reconstruction? And it's not straightforward, but I will tell you that we can never use the MPFC to pull the patella anywhere. We can't pull it medial. So when applicable, we need to correct bony malalignment, and then we balance the soft tissues with medial and or lateral sided surgery. So really begs the question, when does isolated MPFLs fail? And from the literature, we've learned that patients like this, who have the jumping J sign, even the one that the med students can identify, you can see it here, that explosive J sign in CT evaluation, those have substantial underlying risk factors and are really at very high risk for failing our soft tissue surgeries. We also can learn that patients who have laxity and or apprehension into deeper flexion, so not just at 0 and 30, but at 60, and here you see even 90 degrees, have all sorts of combined problems that lead to failure of soft tissue only surgery. Here you can see extremes of valgus. You can turn patients prone. You can see extremes of version and or other rotation. And so we must be astute and be ready to address those types of pathologies. And so here are the things behind the scenes in those patients. They have alta, dysplasia, rotation, valgus, lateralized vectors, and likely combinations of thereof. And so be ready to look for those red flags at every patient. There's literature support that these jumping J-steins and extremes of rotation and other problems that we've talked about will lead to failure of soft tissue only surgery. As Bob Taichi has taught us and others, this is really a force vector problem. We know we have the patellofemoral restraints, the soft tissue balancing, and the trochlea, but we have many different force vectors acting through and on the patella and the quadriceps, and these can lead to trouble and lead to failure if we don't know our thresholds. Now, classically, at least in America, we've said maybe TTTG will measure it, and if it's greater than 20, we'll do a TTO. And while sometimes that may be helpful, that's really an oversimplification and it's not wholly accurate. And I think if we're trying to figure this out in a more thoughtful way, we at least have to understand why. So TTTG above 20 is really not just equal to TTO. A couple of things. I mean, TTTG in general can be variable and it's challenging to measure. But more importantly for this talk, what is it actually measuring? We can see from this paper, for example, that TTTG can be a surrogate for femorotibial rotation, for example. Of course, it can also show us about a lateralized tibial tubercle. It can show us additionally in dysplasia about a medialized groove center. And more practically, it's probably a combination of all of the above risk factors. And so when we talk about doing more than an MPFL, what does do more mean? Well, if you're looking at the femur, you might derotate or you might do a distal femoral osteotomy for valgus or a combination. You might treat the trochlea. And if we're talking about the tibia, we might talk about tubercle osteotomy and different planes of osteotomy. We might talk about distal or proximal tibial derotations or the likes. And so there's a lot of different targets for intervention that we need to be aware of. And so this will come down to thoughtful pre-surgical planning. We need standardized X-ray series every time. We need MRIs the majority of the time, if not all the time. And then rarely we can use CT scans, certainly for complex patients or failed patients to help us to really be accurate in our decision making. We need clinical acumen, thinking about, do I need to do more than an MPFL? Of course, first we think, is non-surgical reasonable? And we can get into, that. But for these patients and for this talk, it's a surgical talk. Do I need to do more than an MPFL? A lot of the times we do if they're younger, bilateral, low energy, failed prior surgeries. And those are kind of some of the clinical risk factors that we think about. And then we think about force vectors, lateralized, rotation, coronal, Alta, trochlea morphology, cartilage, subchondral bone, so many other factors, so many patient factors. And then we use our images and we measure precisely. And I measure all of these things on the screen every single time before I make decisions. So it's really a checklist and an algorithm systematically going through and asking myself when I need to do more than soft tissue balancing. So now we'll go through the patella instability toolbox. And there are a lot of different tools that we may use in addition to MPFC reconstructions. The first tool that I think everyone should have is lateral retinaculum lengthening. This can be used for fixed lateral tightness or fixed patella tilt. Again, we can't pull the patella immediately with the MPFL, so we need to balance the soft tissues, balance the bones, and then use the MPFL as a check rein to lateral translation. So we've written on this and have videos on this. You can see here, this was taught to me by Jack Farr and Liza Arendt, but we're basically exploiting the plane between the superficial oblique and the deep transverse and capsular layers. We can typically peel down the oblique layer, then we can cut through the deep transverse and capsular layers. We can affect a 2 centimeter lengthening. You can see how you can nicely and easily access the joint if you need to do cartilage restoration, but you can also do this as part of your routine soft tissue balancing in some of your patellofemoral patients. So this is a good thing to practice in the lab and then to have in your arsenal. So now we move to the other workhorse, TTO, and when to do a TTO in 2024, frankly, is confusing. We wrote this paper 10 years ago, probably need to rewrite this paper with contemporary and evolving thoughts and concepts. But to cut to the chase, I do TTOs for instability, anteromedializations to unload cartilage, that's my main indication, and then sometimes to correct lateralized force vectors, particularly if I'm not going after subcritical values of other things like rotation or lower levels of trochlear dysplasia. For distalization, I do this for extremes of patella alta, and I'll show you thresholds in a moment. Isolated medialization, almost never do that in my practice. So really the two workhorses for instability are the two above or combinations of those. So for the unloading cartilage, this comes down to mapping where the cartilage damage is. And Jack Farr and I did this infographic that I'll go through. But basically, we can see that if we have these distal lateral defects and malalignment and instability, we can do our anteromedialization, our classic Fulkerson without cartilage restoration, and we can replicate the excellent 87% results that John showed many years ago. However, in the same kind of vein, if we have larger medial, central, panpatella cartilage issues, it's not typically enough just to do the anteromedialization. Those patients actually didn't do as well in John's series and other series. However, if you add cartilage restoration and of course add your soft tissue balancing, then you can get the outcomes up to 75 or 80%. When to add distalization, is a moving target. It is a bit controversial. Biomechanical studies, this one at HSS, might suggest that there's anisometry of the MPFL as low as a Catan de Champ of 1.2. However, when we look at clinical studies and contemporary thinking, most of us are not pulling the trigger on Alta until the Catan de Champ is at or above 1.4. And we can discuss this further as far as what our thresholds are and whether they're moving higher or lower and when and why. It's an important point to note that for AMZs, the Fulkerson osteotomy described in 83 is an absolute workhorse. It gets the job done. It has a low complication profile. You all need to learn and be able to do this. However, when we talk about distalization, it gets a little more dicey. In my own hands, my own series that I presented previously at national meetings, I had basically zero hinge-related issues or complications as far as healing with my AMZs. But when I moved to distalizations and unhinged, they went up to 12%. And that's really challenging for me and my patients. And so I was looking for some guidance on this particular issue around 2017. I was fortunate to go to the Patellafemoral Study Group and to live near the late and great Al Merchant. And Al had been thinking about novel design techniques for TTO, not just for AMZ, but for the other techniques for many decades. And here's kind of what this looks like. Al thought that you could take a series of triangular wedges, either one or more, and then you can basically move them around and you can affect change, medialization, anterization, distalization, AMZ plus distalization. So there was a lot of creativity in that option when you're able to take a wedge cut. Most importantly for me, when I'm distalizing, this wedge cut gives me excellent stability. You can see I can measure precisely and get my 8 millimeters or 10 millimeters of distalization. I want to get my Catan de Champ to 1.1. I can also measure anterization. I can measure medialization. I like to use headless screws with my fixation. And so my harder removal rates have plummeted since doing that versus headed screws. You can also obviously use small screws as well and multiple of them. But this has been a nice adjunct for me for tibial tubercle osteotomies, particularly for the more complex ones. And here you can see bone grafting the proximal buttress, getting our patella height normalized, stabilizing the soft tissue with the medial patellofemoral ligament reconstruction as well. We presented our cohort at Herodicus. And I'll show you just a few things here. The most important for this talk is that when we looked at the distalization group versus the AMZ group, there were no warning signs or early problems or differences. And so I was quite comfortable in continuing the evolution. We have almost 100 patients now, many of whom have distalizations, and will continue to actively collect and report on our outcomes. John's been gracious enough to do a series of biomechanical studies looking at AMZ with the different techniques and distalization and anterization and others. And so I think we'll continue to iterate on this. And I think it's a really exciting avenue that will help a lot of our young doctors really be able to reproduce these types of complex osteotomies in 3 dimensions in their own operating rooms around the country and around the world. Here's a typical complex case: bilateral dislocator, every risk factor under the sun, Alta, dysplasia, lateralized force vector, J signs, pain and swelling between episodes, substantial amounts of chondrosis at a young age. And so this one needs basically the kitchen sink. We do an osteochondral allograft for the patella. We do our intermedialization plus our distalization. We do a bumpectomy, or what's called an entrance trochleoplasty. I'll talk about in a few minutes. We get the soft tissue balanced. And you can always tell with big surgeries when people are happy because they come back for the other side, which to me is quite fascinating and also very rewarding because these are challenging situations to get right. I looked at 144 of my own patients with refractory patella instability, this kind of a la carte thinking, soft tissue balancing always, TTOs per the indications I described, cartilage restoration per the indications I described. I think it's important to note that only a small subset actually needed cartilage restoration. So we can unload a lot of the joint without aggressively treating the cartilage with transplants or cell-based repairs. But interestingly, the patients who needed cartilage restoration started off with lower baseline scores, but at the end of the day, they all got to the same level with no differences in the complication profiles. This is an interesting concept for me that is kind of humorous, but I think it's true. That TTOs for patellofemoral instability are like a toilet plunger. It's a familiar tool and it solves problems. It may not get to all of the root causes of the issues. It doesn't critically always correct every rotation or every misshapen trochlea. But at the end of the day, these are familiar tools with a low complication profile. And frankly, adding TTO to MPFLs as a first line, second line procedure is a really good strategy, in my opinion. The evidence supports this. If you look at these papers, yeah, these patients had multiple other risk factors, but MPFL TTOs were able to solve their problem. So I think we have to keep that in our minds. That said, don't ignore extremes of other things like femoral version. There's clearly literature to support derotations. And when you have patients like this with severe dysplasia, derotation, failed prior surgeries, then maybe going to the tubercle is not the answer. And we can look to the literature, and these are rare, but these are real. And we can plan and execute derotations, and we can take very large supratrochlear spurs, and we can get the trochlea flush to the anterior cortex, and we can really get 2-quadrant medial to lateral translation. We can get excellent stability at 30 degrees and beyond. We can create that tibial tubercle to sulcus angle of 0 right down the middle at 90 degrees, which is basically the goal that I have for any of my patellofemoral instability surgeries. If I can do that with MPFL alone, great. If I add a TTO and that works, great. If I need to do something much bigger like this rarely, then that's what we have to do. And these patients really respond well when you get the force vectors and you get the morphology correct. And so here's the kid, I think, at 6 months on his way to recovery. Other things like extremes of valgus, that's important. And you have a kid like this who has asymmetry of valgus, patella and lateral sided problems in cartilage, trochlear dysplasia. You can again be thoughtful about it. You can treat the cartilage. You can do the realignment osteotomy to correct his valgus to neutral. And then you can do your soft tissue balancing with the MPFL and on the lateral side. And you can see here at 6 months again, we have excellent quadriceps activation. We have good stability, good gait. He's not back to sports yet because this is up to a 2-year recovery for these bigger surgeries. But I think, again, we can solve this problem in many different and thoughtful ways. Which finally leads me to trochlear dysplasia, which is truly our elephant in the room. We know it's sitting there as a risk factor for instability, and it's sitting there for a risk factor for arthritis. But the real question is, when do we push that elephant? And I visited David Dejour, our world's thought leader on the problem. And I think what I learned is that specific treatment of the trochlea is fairly rare. David Dejour has patients referred for trochleoplasty every day, and he does about 30 per year, 2 or so per month. That's not a huge number. So how many should all of the rest of us be doing, I think, is food for thought. When do I consider it? Well, rarely, but it has to be the really, really right patient, super high risk, like the ones I've described, the right imaging with this very large anterior prominence, this convexity on the axial images, and then it really can't be effectively unloaded or stabilizes with any other technique that I know of. That's tibial tubercle, that's osteotomies, that's osteochondral grafts, that's patellofemoral arthroplasty or the likes. And so, this is really a rare and select group. David Dejour does the thick flap trochleoplasty, as you can see here. Some will do a thin flap trochleoplasty, open or arthroscopic, as you can see here in this video. This is from David Deduk, who has been a thought leader in America on the topic. You can see how you can take that supratrochlear spur and get the entrance of the trochlea flush to the anterior cortex. You can also contour the groove proximally and even into deeper flexion. Here's a second look, and you can see the cartilage tolerates this quite well. And there is some literature support at mid and starting to be long-term that supports great stability. It supports clinical and functional outcomes. However, there's not a tremendous amount of literature on this, and we need to follow these outcomes carefully. Jason Coe looked at this in a dynamic simulation, and yes, trochleoplasty did stabilize, but at what cost? He had elevated contact pressures. Is there a longer-term OA risk? I think more questions than answers there. If I have patients with severe chondrosis, we obviously can't do trochleoplasties. So we basically, sometimes in rare cases, can actually do osteochondral grafts to reshape and make a groove. And then when I have older patients with instability and chondrosis, we can do metal and plastic to make grooves and then do soft tissue balancing as well. So many different ways to get the job done for the trochlea. This is a concept we should all know about because it's easier when we might think about doing a Peterson grooveplasty or an entrance trochleoplasty. So think about a patient like this with a supratrochlear spur, that large J sign. They have a long trochlea with a very high crossing sign that's flush or close to flush with the anterior cortex. Well, what if we just lopped off that supratrochlear spur? Basically akin to a ski mogul where we groom the ski slope. This is technically easy. There's less morbidity, but there's not a ton of information on when exactly we do this versus deepening, functional outcomes, arthritis risks. So more questions than answers. The group from Mayo looked up their series in comparison and made some interesting conclusions and findings that lead us to continue to investigate grooveplasty for sure. But I can't tell you exactly who and when to do this in. Future directions. This is complex. I can't give you a full algorithm today that because it's ever changing. I think it's ripe for machine learning. We need big data. We're partnering with the Jupiter Group, and I'm grateful to that. And I think we'll learn a lot of interesting things on how to treat patients better over time. When to do more than just MPFL or MPFC surgery. Patient-specific guides have opened my eyes to some of these more complex rotational problems on the femur and the tibia and combined problems. And I think that they help us all to measure precisely, plan appropriately, and then execute in a timely and safe fashion. And in conclusion, after that whirlwind that Miho asked me to cover, the MPFC rules until it doesn't. So we need to be really astute in understanding the red flags when we might need to do more. Instability is extremely complex. It's multifactorial. We can't cover everything in this one session, but think about the force vector problem and when you need to solve it. Think about the extremes of the morphologic or the shape problems and when we need to fix those to balance the patellofemoral joint. Most importantly, study outcomes. Stay humble and continue to learn. I'm grateful to John, Patellafemoral Study Group, and everyone on this journey with me. We have the Patellafemoral Foundation modules, which I think really get you all up to speed and in the game on these current concepts so that you can join the conversation. And I thank you so much for your attention. I look forward to John's talk, and I'll answer any questions either in the chat as we go along or in our discussions towards the end. Thank you.
Seth, not to widen the scope of what we're talking about, but can you talk a little bit about valgus and femoral aneurysm, which obviously play into this? And I know you showed a couple of slides about, considering these things. But for you specifically, when you're looking at instability, how do you factor that in? What are your cutoffs that you're looking at, and how would you go about kind of assessing and addressing both of those?
Yeah, sure. I think the key point is that we're always looking for them in every patient. So we're always doing that standing evaluation and the prone evaluation. And in my practice, which is obviously a tertiary center, I'm getting long leg mechanical axis views in those patients. And if I have a low threshold, or if I have suspicion for a rotational problem, I will go ahead and get the CT scan. We actually build into our MRI surrogate or just spot images of the hip and the ankle to get some cursory information, not perfectly accurate, but it gets us in the ballpark, right? So I guess understanding when we need to do more, and then whether those are real, true major outliers. One thing I learned from Bob Taitchi, again, that he has a great slide on this, that, valgus is one of the major drivers of that lateralized force vector for patella tracking. And when you combine even, smaller amounts of version to that and large amounts of version, it overwhelms the system. So, I think we don't want to miss that. We'd be missing a tremendous amount of the problem. And I think when we leave America, we're seeing a lot of treatments are moving towards rotation and moving towards valgus, and to some extent moving towards trochlea, for better or worse. And so, I think bringing it back to practical and reality, I'm still not treating those things with a tremendous amount of regularity.
Yeah.
Most of my patella instability patients are getting isolated soft tissue procedures. When I need to do more, the vast majority are still getting TTOs for Alta, or unloading and medialized vectors for chondrosis. And even if they have 3 degrees of valgus or, version that's getting close, I'm not pulling the trigger on that in those, certainly not first timers, and maybe not, on low elevated or, subcritical values. Things that will move me in that direction, like obviously if they have lateral compartment cartilage issues as well, and I need to treat that, or if they're, TTTG is borderline or low, they don't have version and they have like 8 degrees of valgus, that's the main driver, I'll go there. If everything else at the tubercle is normal and it's femoral rotation that's obvious with severe trochlear dysplasia, I mean, that's a variant, and I'll go there. But I guess always think about it and don't always act on it. I like to do things that are multiple standard deviations outside the bell curve, and asymmetric to their other side. So that's when I act on it. But I mean, I'm not going to correct version for less than a 15, 20 degree correction. So it has to be outside the norm by that amount. So that's a lot of version. I'm curious to your thoughts on this too, if we're in a similar place, or if your thresholds are a bit different.
Yeah, absolutely. I think I agree with you with the valgus. It's really when I start to see any sort of lateral compartment problems that, makes me think a little bit more about correcting that. For version, I'm very conservative with that. So, oftentimes it's kind of in line with a higher TTTG. And so if the version is high, but the TTTG is also high, I think a lot of patients really tolerate the TTO, and can get that correction in their vector without really going, to all the way to do a derotational osteotomy. So just for the audience, you've obviously got a complex patellofemoral practice, plus everything else that you do, cartilage and all of these things. But for your patellar instability patients, can you just give us a sense of like what percentage of your patients are getting an isolated MPFL, MPFC?
I mean, I'd have to look at it, but I mean, I'm also in
Absolutely.
Jupiter where we're trying to
Yes.
enroll the majority if we can.
Yeah.
I think probably I hope it's like 30-40%, I guess, in my practice.
Yeah.
It's probably more in most people's practice, I would say. And then it's the TTO, MPFL, which is that extra subset. And then the other things are more rare. We'll
Yeah.
turn it over to John in a minute, but just two more quick points on that rotation issues. TTPCL might be helpful. If the TTTG is high, your version's high, you may have a lateralized tubercle. You can maybe use TTPCL or other measures to look at if the tubercle is truly lateral or not. That's one thing. Throw out there, helps with decision making. And then if I didn't have patient specific osteotomy, I'm not jumping leaps and bounds forward on trying these distal femoral and other things that I wasn't taught in fellowship. So it's been an evolution because of tools and technology and because of education with people like yourselves.
Yeah, awesome. Thank you. All right. I think we can see your slides.
Okay, great. Thank you.
Thank you.
All right, well, I'll go ahead and start. These are my disclosures. Next slide. So Dr. Tanaka went over this a bit, but for this specific talk, the learning objectives that come to mind are knowing the medial patellofemoral complex anatomy. We're going to shift a little more heavily that way and understand how to do anatomic medial patellofemoral MPFL or MQTFL in my case, since that's all that I do. Understand when to add a tibial tubercle transfer is appropriate, as appropriate in patella instability surgery. Dr. Sherman's talk was truly superb. It's the best I've ever heard on the cumulative topics that we deal with in making this decision, and really, really excellent and up to date. Tough act to follow, but I'm going to take a little different track. Next slide. Okay, so this is really a summary of what I'm going to have to say, and that is currently we make decisions on 2D images, often using MRI. And we're trying to decide when to do this fairly complicated surgery, and the decision-making really gets so much better when we have 3D images. So the work that we've been doing currently has focused a lot on 3D because we feel like we get a much better handle on what's going on. Next slide. Okay, so as Dr. Sherman said, we need to understand the patella tracking mechanics before doing any medial patellofemoral complex reconstruction. And some people may need a tibial tubercle transfer or a medial ridge resection, which he also talked about. So one of the measurements that we make routinely now is what we call the EPTG. So if you look at the line on the right, that starts at the center of where the patella comes into the groove. That would be the entry point for the patella. And we draw a line from that to the top of the trochlear groove, and then a vertical line that's perpendicular to the distal condyles, and measure that angle. Next slide. So that's the same angle you see on the left there, article published in Arthroscopy 2024. And then the other angle we look at is called the EPTP, which goes to the transition point. So the entry point, which is the dot where the patella comes in, and I understand this is going to be a new way of thinking for you, but just to give you a feel for how this 3D helps in decision-making, that entry point goes then to the point where the trochlea straightens out. And this was a concept developed by Kristen Yu. But it's actually really helpful because what that's saying is the patella takes an oblique path from where it enters the trochlea, and then it kind of zooms over there to the center of the deeper trochlea. And it's that first part of the trochlea where the problems are, where the patella is prone to slip out of place, and where the idea of doing a trochleoplasty, deepening a trochleoplasty, has come up, because it is vulnerable up there, and particularly when it's coming from so far lateral. Next slide. So this is a base study that I think we all need to think about, and that is that if you do MPFL reconstruction, in this case, despite any type of trochlear dysplasia, B, C, or D, you can make the patella stable. The problem is that this study didn't include everybody who had a TTO, because there were some people with alignment disorders that were more severe and articular lesions who didn't have a TTO. So it is a select group, but it is people with trochlear dysplasia. So a medial reconstruction alone without a trochleoplasty can certainly work in the setting of trochlear dysplasia. But we want to do a tibial tubercle osteotomy when needed to optimize long-term joint stability and preservation of the joint. So that's a kind of a working idea that we have, and what helps us to decide when to add the TTO. Next slide. So now I've learned a lot from Drs. Tanaka, Dr. Sherman, many others. You pull it all together. I think tibial tubercle transfer is the best way to get the patella to the deeper central trochlea sooner. That's a little different way of looking at it than we have looked at it in the past. Adding distalization for Caton-Deschamps ratio over 1.3. You know, there's all these, Dr. Sherman talked about 1.2, 1.4 is a common threshold. I use 1.3. And if we want to align only, we just need to move the tubercle medially. But intermedialization, as Dr. Sherman said, is powerful because it aligns, but it also allows us to unload lesions. And the other thing we're starting to realize as we look at 3D models is that we can lift the tip up and help it to bypass that proximal spur. And again, it's that proximal spur that comes into that difficult elephant in the room. So how much do we do about that? Do we just knock it off, which is one option? Do we bypass it with a distalization? Or do we just kind of get the patella by it? So with 3D, what we're finding is we can figure out ways to get the patella by it. And sometimes we do recess it. So we're basically on the same page. Next slide, please. So this is just a very simplified way of looking at it. And it is a little too simple, but at least it's a baseline that kind of works for a lot of people. If the patella remains lateral on a 30-degree knee flexion axial, and again, that has to be an exact 30-degree knee flexion axial, not a sunrise view. So we work with our techs and we send anybody back who has more than 30 degrees flexion. And you can tell because it'll be in the deeper trochlea too soon. So you can really determine for sure and work with your radiology technicians to get that view every single time, which is necessary. An anterior medial tubercle transfer becomes more valuable when you want to offload a distal or lateral lesion or bypass a proximal spur. And distalization is pretty powerful, and it does add potentially a little complication. I agree with Dr. Sherman's approach. He has a method now and instrumentation to make this more stable, more reliable. And I think that's something we all need to look at also. But one way or the other, distalization is powerful. It helps to bypass the spur and it helps to get the patella to be more stable. What it really does is it advances the patella. This is a new way of looking at things, but it's what we're learning after 4 years of 3D. It advances the patella a little further down that bobsled track or the trochlea. It's kind of like a bobsled track. So more on that later. Next slide. So this is a little exaggerated. It is a real patient that was sent to me. These images were sent to me, but it does make a point that you take what's actually a very smooth, flat surface, and with deepening, you make it into an incongruous groove. And yes, that will make the patella stable, but we have to ask ourselves, as Dr. Sherman showed very nicely, well, what does that do to the joint long term? And there are studies showing that down the road, 15, 20 years, these joints almost all become arthritic. Next slide. Well, I don't think that has to be the case. I really, really believe now that I look at this, that we can make these joints stable without leaving people with a knee that will inevitably become arthritic. And when you look at the numbers that Dr. Sherman mentioned, there are not many people that really need a trochleoplasty and even fewer who need a deepening trochleoplasty. I mean, I essentially don't do deepening trochleoplasty, so I'm on the same page with Dr. Sherman. I'll remove that little bump you see there on the right and just help the entrance be a little smoother. And then I'll bring the patella down a little bit when it needs to be, correct the alta, get it in the groove a little sooner. So we literally think of this as like a bobsled run. You just bring it down, get it a little closer. The next slide. Get us closer to the deeper trochlea. So now when you look at it in 3D, particularly if you look at that cartilage, that's articular cartilage printed in 3D, you can see that's congruous. That's a dysplastic knee, but it's congruous. So anything we do to that joint, we're going to make it incongruous. So if you look at that image on the left, you can see the patella there starting way out on the lateral side. It's got to go around that lateral trochlea. It's got to come around the bend and get into that deeper trochlea. If it sits up on top there, next slide. This is some contour imaging that we do, and it's a little hard for you to appreciate, but the yellow there is the concave groove, and then you get up into the more convex lateral side to your right, and you get into a situation where that patella can kind of be pulled a little bit over that prominence there, and it can become pretty prone to dislocation, basically. Next slide. So along comes Dr. Beitler, who's worked with us and identified the entry point and the TTTG in 3D as being really important, but awareness on viewing 2D is helpful in estimating the laterality of entry. So what with the EPTG angle that he defined, over 30 degrees, we now have a number when we look at all of our normals. This is published now in arthroscopy. Beyond 30, when you measure this particular measure, that patella is too far lateral, and the people who are prone to dislocation who dislocate recurrently have EPTGs typically over 30. Next slide. So this is an issue of lateralization. And yes, developmentally, those trochleas become flatter. And this is Johannes Sieber's idea. He's a young engineer who works with us. Basically, we want to get the patella to stay on the correct side of what we call Mount Johannes Sieber. He's the one who talked about this concept. It's a very simple engineering concept. We need to get the bobsled to stay in the track. And sometimes we need to advance the bobsled a little bit to get a little closer to the deeper part of that track to make sure it stays in the track and it doesn't go flying off the side of the track. Next slide. Very simple concept. If you look at this 3D image and you look at the entry point on the left there, that patella, or the bobsled analogy, has to get from that point to that deeper trochlea. And once it's there, it's pretty well caught up. There are people who dislocate in flexion, but that's pretty rare. The people we're talking about mostly are unstable in extension, and they're the ones that get the recurrent dislocations and the problems that we deal with more commonly. And we know that that entry point is right between the ends of the two ridges. So there's a different way of looking, and you can get these 3D CTs pretty easily. It's just a CT scan that they prepare in radiology for 3D imaging. You can see it right through the radiology software. You can look at them in Scan IP too if you want. Next slide. And then we do think when you start off on that lateral side with hyperloading there, you're going to be prone to arthritis. So there's a lot to be said for getting more stable by moving it. So you look at this. Okay, now think of this as a bobsled track. You want to get that patella. You can actually see the entry zone here at the end of that medial ridge, which is right towards the center, and that big spur. You say, okay, now if I just advance that a little bit, I get it in that track a little more and get it so it doesn't ride up on that mound of lateral trochlea there where it could slide off the side and dislocate. We want to keep that in the track. So that's the concept currently that we use in terming when to do a TTO. Again, with the interiorization to bypass that bump a little bit. And yes, we will recess that bump also, basically exactly what Dr. Beitler was talking about. But if one were to do a deepening trochleoplasty here, now you can see you have a very smooth surface. Again, the bobsled track analogy works because if you deepen that, you're going to grossly distort that track. And the person who's in that bobsled going down that track, once you deepened it, maybe they'll be stable in the track, but they're not going to be very happy when they go over the speed bump and they hit those incongruous surfaces. So I think that analogy works pretty well. Next slide. So tibial tubercle osteotomy, Dr. Sherman has talked about very well. It's not much need to go into that in a whole lot more detail. Next slide. Dr. Sherman himself was quoted back in 2018, I think, at the 2019 AOSSM meeting, and other studies now with Serkan Yalçın and Latul Farrow have shown, in Sabrina Strickland, that adding a tubercle transfer really doesn't add much risk. Next slide, to the MPFL reconstruction. We also know that if you do move the patella and you keep it in the track, and this person who had a TTO 29 years earlier, one advantage of being in this game for a long time and didn't have it on the other side, you can see the difference. So the TTO is a joint preservation procedure. Next slide. Next slide, please. Yeah, that's what we're talking about here. It's not that complicated, really. The decision-making is complicated. And here's the midpoint of the medial patellofemoral complex that Dr. Tanaka described in 2016. It's right there at the proximal patella. Next slide. That's viewed from the deep side. This medial complex is very complicated, but essentially Tanaka's point defines where we need to attach these grafts. Next slide. Next slide. So we'll go through a, basically what we do is follow the adductor magnus down to its insertion point, and we attach it at the location between the adductor tubercle and the medial epicondyle, the saddle region, and then bring it up through the quad tendon, as you see here, loop it around. That's it. That's all you need to stabilize it there. Next slide. So we're heading right to Tanaka's point. You can see the left arrow going to the adductor tubercle, the right arrow to medial epicondyle, and then we put it right between those two. Next slide on the femoral side. There's that tendon, adductor magnus. There's the old medial complex, this cadaver knee. You can see the red arrow on the medial epicondyle, blue on the medial adductor tubercle. Next slide. Go through these pretty quickly. Drill the hole right there. Next slide. And put your graft there at the saddle region. Next slide. Bring it up under the vastus medialis. Next slide. And then we just loop it around, bring it under the VMO, right to Tanaka's point, loop it around the quad tendon. Next slide. And that's what it looks like. So very easy to tension because you just flex and extend it to bring it out to length. Next slide. And then suture it to maximum length, as Jack Farr has called it, setting it to length. So we can avoid patella fracture completely by doing this. Next slide. And leave just a little bit of play in it, one quadrant of lateral translation. Next slide. And that's just if you can run that video. Just this is what we're looking for, to get that stable. And that's good to go really for the rest of his life. And I really believe now that this is going to be joint preservation as well as stabilization for the long term. So we don't have to look forward to arthritis in 20 years. Next slide. Thank you. And you can find a lot of education material here if you're so inclined through the Patellafemoral.org website for the Patellafemoral Foundation. Thank you again.
Well, thank you so much for those excellent talks. I know we're kind of just coming up on the hour here. There was one question in the Q&A which I addressed. If anyone has any burning questions for the final minute or so, please feel free to enter them in the chat. Otherwise, I think I would hate to start a discussion and then run over, I think, but, just to kind of sum up, and we went a little bit backwards here, but I think the point is that, from the perspective of soft tissue stabilization, there are obviously a lot of options and that this area is rapidly evolving. And even though that ends up being a great option for a lot of these types of instability cases, as Dr. Sherman has covered, there are multiple other considerations that don't always necessarily all have to be addressed, but we should be assessing them carefully. And I think that this area is continuing to evolve and become a little bit more precise as we move forward with, better imaging technology and better understanding of long-term outcomes after these procedures. Any final words from our speakers tonight?
I have one comment. If you're going to learn anything about patellofemoral instability surgery, learn how to do MPFC reconstructions well, because that is what's going to benefit your patients mostly. You've seen John using anatomy. We also use fluoroscopy. We use isometry. We set the length. We don't tension. And these are critical principles that cover like a ton of this, right? And then there's the nuance and the salvage and the really hard patients. And then my only other point there on just trochlea in general, we don't agree on how to classify in many cases. So we're talking apples to oranges. Every apple is not an orange, and every trochlea is not the same. And as John, I'm sure in his 3D sees, they come in many different flavors than just A through D and or convex, flat, and shallow or normal. So until we really are thoughtful with making sure everyone's classifying exactly the same, then it's really hard to come up with one standard worldwide treatment for it. So just be cautious as we learn, I guess would be my message.
Great
Yeah.
words. I agree with Seth 100%. And I would just add briefly that the worst problems we see, or at least that I see, are from poorly done MPFL reconstructions. It can be a real killer. I mean, just destroys cartilage. It really can be devastating. So just like an ACL, any other surgery, you've got to be anatomically exactly right. And just study that anatomy before you go in there. And if you do it anatomically, you'll it's a great operation, very consistent, works well for people.
Okay, great. Well, we're only 1 minute over. Thank you so much again to our panelists, both of them who are obviously amazing experts in this area. I myself had a chance to learn a lot from both of you, and as I always do. So thank you for being on, and thanks to all our attendees for being here tonight.